So it's almost 8 o'clock. I think if Dr. Somasundram joins, we can.
Yes, madam.
Just call him. Yeah.
He'll just join in a bit. Once he joins,
I think he has joined now. We'll start. Yes. Welcome, Jalil sir. Welcome, Dr. Somasundram.
Hello.
Good evening.
Good evening, sir. Good evening, Jalil sir.
So.
Somasundram sir, good evening, sir.
Yeah, good evening, Prasanna. Good evening, Dr. Suresh. Good evening, all the faculties. Yeah, good evening, MSV Boss, Dr. Rajkumar. Good evening, welcome. Yeah.
So can we start the program?
Yeah.
Okay.
TN Mano sir.
Manohar sir, ஒரு கால் பண்ணவா?
ஒரு தடவை just
Yeah.
I have joined with my mobile.
நர்மதா நான் கூப்பிடுறேன், நீங்க ஆரம்பிச்சிருங்க நர்மதா.
Okay, fine. Yeah. Thank you. So a very warm welcome to all the people who have joined us on this platform today, and we are into yet another interesting series of specialty chapter, which was a novel How Idea Started. I request Dr. Rajkumar sir to give the pediatrician player, and I would hand over the platform.
Thank you, Narmada.
Raju of Pi to take over the proceedings.
Pediatrician prayer. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed the ability to annihilate suffering. May we be instruments of health, learning, charity, love, peace to all children and their families, irrespective of status and faith. Give us the wisdom, understanding to change the things we can, retain the good, and accept within reason the things we cannot change. Grant us your blessings, grace, and mercy in all situations, at all times, amid all people. Thank you. Over to you, Narmada.
Thank you, sir. So, with this, I welcome you all for the CME for Pediatric Allergy and Applied Immunology chapter, Tamil Nadu chapter. On behalf of Pediatric Applied and Allergy Immunology Tamil Nadu chapter, as a secretary, myself, Dr. Prasanna, welcomes you all for this. May now request Dr. Somasundram sir, President IAP TNSC, whose brainchild is this program. Monthly one subspecialty talk for the Tamil Nadu state chapter, and it travels through the nation actually. Not only this program is brainchild program, a lot of programs like virtual Gurukulam, everything is now a hot favorite across the nation. Sir, with these few words, Somasundram sir, can you just inaugurate the program?
Yeah, thank you. Thank you, Dr. Prasanna. So, good evening, all the dignitaries on the Zoom platform. Our past president, Dr. Rajendran, Dr. Thiruvurugan, our president-elect, our vice president, Dr. Vishwanathan, our secretary, Dr. Narmada, our treasurer, Dr. Rajkumar, the executive board members and the office bearers of IAP Tamil Nadu state chapter, the office bearers of the special IAP Allergy Tamil Nadu state Allergy and Asthma chapter, Dr. Suresh, the secretary, Dr. Prasanna Raju, and the treasurer, Dr. A.M. Karthik, and all the faculties who have joined on this Zoom platform, Dr. Soumya, Dr. Neeraj, Dr. Krishna Mohan, and Dr. Suresh. So welcome you all for this specialty series. So when I took over as this president, so I found that there are about 8 to 9 specialty chapters which are functioning in the IAP Tamil Nadu state chapter, and many are they have a lot of inbuilt talent and people with a lot of talent, but we are not able to organize a specific conference for a subspecialty chapter every year. So we thought every month one specialty chapter should do a CME, online CME, on the last day of the month. And this was successful for the last 3 months. The first month was an ID chapter, and the second was the adolescent, the growth and developmental pediatric chapter. The third was the adolescent chapter, and now
हाँ उसी की बात करें, बाहर से लोग मजा आता है।
You take the
request, he
One
she
second.
is the host actually. He is the host
Prasanna, you have to
actually.
mute everyone,
Request
Prasanna.
Dr. Swati Kalre to mute herself. Yeah, thank you. Yeah, he is a host.
So this is the turn for the allergy chapter to showcase its what I say is the program today. And thank you, Dr. Prasanna, Dr. Suresh, and Dr. Narmata for taking the lead and bringing in all the faculties from all over the country to be the this session will definitely be an eye opener for all the people, private practitioners and the postgraduates who have a keen interest in managing allergy cases. So wish you all a happy learning for the next 90 minutes, and thank you, and over to Prasanna to carry out the further proceedings. Thank you very much. Yeah.
May now request Dr. Narmada, Secretary, to speak a few words.
Yeah. Thank you so much, Dr. Prasanna, and I'm very thankful for my dear friends, Dr. Soumya, Dr. Neeraj, and Dr. Krishna Mohan, who accepted it immediately to come and talk on this platform. I've been wanting to call them a long time, and we will do so physically also when we organize our own allergy program here. They have been very enthusiastic, and they have put allergy chapter at a totally different level in the national platform. And we also have released national guidelines for the first ever from our allergy chapter. I'm very happy to be a part of the team, and I'm very happy that many of our Tamil Nadu people have taken a lot of keen interest in allergy and asthma and are doing various programs at the national level. Having said that, the entire module today we have planned such that it will be very useful for practicing pediatricians so that they can use it immediately in their practice. I hope you have a great learning today and happy academics, and looking forward for the sessions. Thank you, President.
A few words from Dr. Thiru sir, President-elect, Tamil Nadu State Chapter.
Thank you, Dr. Prasanna. I think it's really the need of the hour that we are having this subspecialty series. Pediatrics, as we all know, has expanded quite a bit, and we need the inputs from the stalwarts. And I'm really happy, and I would like to congratulate Dr. Somasundaram for his initiative on the subspecialty chapter series of every month. So I'm very sure like the previous two sessions, this also would be a great success, and we are very happy to welcome all the national faculties who are on the platform today to enlighten our people. Thank you very much, and best wishes.
Thank you, sir. A few words from our academic coordinator, Dr. Manohar, sir.
Sorry for joining late. Actually, Dr. M.S. Viswanathan only reminded me. Sorry. Actually, yes, as a subspecialty chapter, this allergy case scenarios will be very useful because at least every month, all of us will be facing allergic disorders in our practice. So this is going to be a very useful session, and let us have happy learning. Over to you, Dr. Somu.
Thank you, sir. A few words from Dr. Vishwanathan, sir, Vice President.
Yeah, good evening.
Tamil State Chapter.
Nice to see our monthly subspecialty CME going on very well, and kudos to Somasundaram President, our past President Dr. Rajendran Thiru, the President-elect, Narmada and Rajkumar, and our academic convener Dr. Manohar. Nice to see the allergy chapter bringing out very good faculties today. The lead Dr. Suresh, Dr. Prasanna, and Dr. Karthik. Nice to see Narmada being there, and also my friends Dr. Krishna Mohan, Dr. Neeraj, and Suresh again being there. And of course, nice to see Dr. Soumya Nagarajan. I'm sure this is going to benefit everyone. Thank you very much.
We do acknowledge the presence of Dr. Venkateshwaran and many of the stalwarts, Dr. Jalil, who have joined, and we will be able to hear from them as the end of the program here. Thank you so much for joining us and encouraging.
I also welcome Dr. Suresh. Dr. Suresh is a Tamil Nadu chapter chairperson right now. We formed this PAA Tamil Nadu chapter last year. Dr. Narmada was the first chairperson. Now Dr. Suresh has taken over. Dr. Suresh, a few words from you.
Thank you, Prasanna. So I first of all, I congratulate and Dr. Somasundaram and Dr. Narmada and Rajkumar for doing this excellent academic activity. I know all of them for many years, and anything academic, we can tell their name actually, and a lot of academic activities is happening in this year actually is going on, and their special interest on allergy makes us to be more happy. And I also thank Dr. Vishwanathan also for doing this, involving in this activity. And our friends Dr. Neeraj and Dr. Krishna Mohan and Dr. Soumya, they are all stalwarts of allergy. And today we have a program with all of them in our allergy chapter in Tamil Nadu. It will be a very good thing to have. So this academic activity, we assure you that how Dr. Narmada did last year, we also try our maximum efforts and to increase this academic activity and improve the awareness of a lot of allergy issues, which is the common bread and butter of practice of pediatricians in our scenario. So we will do our level best. Thank you so much.
Thank you, Dr. Suresh. With all the office bearers of State Council, I will start this program. So we all are in T20 mode now. So we know how important is the opening batsman's role. So for that, Dr. Narmada chose Dr. Soumya Rangarajan because there is no other better person to have the opening batsman's role other than Dr. Soumya Nagarajan. So Dr. Soumya Nagarajan is a IAP certified pediatric allergist from Bangalore, and she has finished MBBS DCH, and she has done her fellowship in. She has got a fellowship in American Academy of Allergy and Immunology. She is also IAP certified, and she has IAP grant. And she had a lot of allergy exposure from St. James Hospital, Leeds, UK. He has done a lot of research, and the area of interest is hereditary angioedema, food and drug allergies. Without wasting much time, I hand over the podium to you, madam. You can please start, madam.
Thank you. Thank you, Dr. Prasanna, for a very kind introduction. At the outset, I would like to thank IAP Tamil Nadu State Chapter for a very kind opportunity to be a part of this academic forum. Also, Dr. Narmada, Dr. Prasanna, and Dr. Suresh, thank you for the opportunity and considering for me for in this academic forum. So, I think the topic which was allotted to me was about urticaria and how it is important for us in our clinical practice. So let us start off with few of the case scenarios which we commonly see in our day-to-day practice, and we will go through the overview about the presentation, pathogenesis, and the management of urticaria, and we'll come back to the cases at the end of the presentation. So in the next 20 to 25 minutes, I will just try to cover different aspects of urticaria. This was an 18-month-old female toddler who had fever, cough, running nose for the last 5 to 7 days, and the child had the above symptoms, which was decreased upon symptomatic treatment from mucolytics, antipyretics, and however, the child developed itchy macular rash over the next few days, lasting for about 3 to 5 days. But the parents here were concerned whether is the rash because of the medicines which were given or any food the child has taken. So the child did become better after symptomatic treatment with antihistamines, but it was recurring. So the question was, is it possibly, what was the underlying trigger for this rashes? On the other end of the spectrum, we have an adolescent girl who has itchy, she says it's a bumpy rash which is elevated all over the limbs for the last 5 months, and it almost occurs every day. She sees that there is no food trigger, drug, or environmental trigger. She tries to keep a tab. she says that when she takes antihistamine, she seems better. However, the rashes recur back on another place the next day. So she is keen to understand what's happening. How long does she need to continue the medications if yes? And is there any possible allergy test she wants to get it done? So how do we define urticaria? So these both rashes which presented typically fit into the category of urticaria, and generally urticaria or hives, which is otherwise called as well, it is wheals. It is defined as circumscribed raised erythematous plaques which is associated with subcutaneous edema. The hallmark features include, which is intensely pruritic. It is symmetrical in nature most of the times with pale center. It blanches with pressure when we apply pressure. It can be in varying sizes and shapes as well. The main thing which is in the pruritus, which is associated with hives, is mainly it is occurring just less than 24 hours at each site, and it recurs back on the other day, without leaving any residual pigmentation or discoloration. If the patient is having concurrent fever, post fever, the child may develop the rashes, but if it is associated with fever, if the rashes are disappearing with the residual petechia or purpura, if it is associated with blistering or peeling of the skin or other systemic involvement such as joint pain, body pain, those do not fall into the urticaria or hives category. So it should be pruritic, blanching, and most importantly, last for less than 24 hours without leaving any residual pigmentation. So if in the urticaria, I think it's important to understand the timeline of about 6 weeks. If the symptoms are lasting for less than 6 weeks, they fall into the acute category, acute urticaria. If the symptoms are beyond 6 weeks, it falls into the chronic urticaria. The 6 weeks timeline is usually taken by, it is well defined in most of our allergy guidelines, because spontaneous resolution of most of the urticaria wheals happen within 4 to 6 weeks. Anything beyond that goes on into urticaria, where we have different subtypes called as chronic spontaneous urticaria or chronic inducible urticaria, which I will briefly touch upon in my subsequent slides. So as we understand, the urticaria, the symptoms are less than 6 weeks in acute. More commonly, we see this in pediatric population, and more so in post-infection scenario. Very commonest, about 80% to 90% in pediatric age group. The presentation could be a post-infection. It could be a bacterial, viral, otherwise parasitic infection, but most commonly we see this, and may be self-limiting. They do not require, most of them require reassurance, a good dose of antihistamines, and we usually do not offer allergy tests if there is an history of accompanying predisposing infection prior to the onset of the symptoms, as in our first case. Having said that, we also here, we could have food, insect, stinging insect hypersensitivity, some drugs, also as one of the causative factors of urticaria, and it could be IgE mediated. In those patients, we could be offering them an allergy skin prick test based on the history. On the other end of the spectrum, chronic urticaria, generally it occurs continuously or intermittently for more than 6 weeks. We see this more in adult population with a female preponderance, and here we do not see any much increased incidence in atopic predisposed individuals like in acute urticaria. When we are talking about urticaria, it's also important to have 1 or 2 slides emphasis on angioedema, because in chronic urticaria, at least 40% of our patients could have an underlying angioedema along with urticaria, and in about 10%, we could have only angioedema also as one of the predominant presenting features. Angioedema is usually defined as the swelling of the deep dermal or subcutaneous submucosal tissues. Here, very commonly, we do not have itching sensation rather than it is patient describes as tingling or numbness, tightness because of the subcutaneous or submucosal edema, because of the stretching of the tissue or a burning sensation. So basically, it is it takes a little longer time than the urticaria to resolve, maybe more than few days, unless like urticaria, which takes less than 24 hours for resolution with recurrence of an other cell. So how do we differentiate between bradykinin versus histaminergic mediated angioedema? Histaminergic mediated angioedema, it could be associated with urticaria. And we do get some history of the onset of symptoms after exposure to that particular allergens, be it food, sometimes drugs or stinging insect hypersensitivity. And hallmark feature is reducing, subsiding within 24 hours. And they have good response to our antihistamines or steroid therapy. On the other spectrum, if it is a bradykinin-mediated angioedema, here predominant conspicuous absence of urticaria and the angioedema may last for a few days. And even if we prescribe them antihistamines or steroids, the patient wouldn't be responding. So in these cases, we should be keeping a high index of suspicion for hereditary angioedema or other causes of angioedema, especially if it is drug-induced angioedema in adolescent or adult population. So if they are not responding to antihistamines, we should suspect that. Coming back to urticaria, I think the main practical issue for us is most of them, even we see put them on multiple antihistamines, we do not see very good control of the symptoms. And generally, this leads on to probable delayed referral, or if we can actually increase the dosage of the antihistamines, the quality of life of these patients are very much affected. The concerns that we see is that if we are giving antihistamine, is it good enough to give for a longer duration of time? Is it safe? Is it associated with any side effects? Sometimes we also hear that antihistamines on a long term should not be given with possible risk of adverse side effects in the long term. So what about the epidemiology? In acute urticaria, I think at some point of time, 25% of the population at some point would have had acute urticaria in their lives. And most of them respond very well to antihistamines. And a small subset, about 10%, may require a steroid. Here, it may or may not be associated with angioedema. In chronic urticaria, we did see that we broadly classify them as two types. Inducible urticarias, where we have a physical trigger, such as vibration, pressure, cold urticaria, cholinergic urticaria, dermatographism. Here, most of them responds to a very good dose of antihistamines like acute urticaria. Chronic spontaneous urticaria on the other spectrum, where previously it was known as chronic idiopathic urticaria, it affects at least 1 to 5% of the patient, and this is a little hard to treat because here only about 40 to 50% of the patients respond to antihistamines and they have associated angioedema. The causes of acute urticaria, as we were mentioning, here I would like to bring your notice to the infection, mainly that is the predominant acute urticarial presentation in the pediatric population. The other causes include food, medications, insect, sometimes adverse reactions to immunotherapy, very rare, especially in subcutaneous immunotherapy, NSAIDs, which are non-Ig mediated, and papular urticaria is another subset. Here it is caused by insect bites, especially fleas. We see this papular urticaria again recurrent, and probably good skin care and good dose of antihistamines would be helpful. The next few slides will be on the dermatographism, chronic urticaria. Dermatographism is unique in a way that here the patients, whenever they say that whichever pattern they scratch, or even we take a pen and if we write in any letters on the hand, in the same pattern, the wheals come up. Okay. So most of our patients we do see is having dermatographism, and generally they contribute to about 5 to 10% in chronic urticaria, and a good response to antihistamines. The other types of inducible urticaria, I wouldn't go much into the details here in the interest of time, but we have different type of urticaria in inducible urticaria, such as dermatographism, other than that cholinergic, where the patient after bathing, on exposure to higher temperatures, or somebody who's in sun and after sweating for some time, they break into hives, and delayed pressure, where children or adults, if they're having a backpack which is a little heavy, and after some time we may see that wheals may be appearing in that particular area. Sometimes we have colder urticaria also, especially when they are exposed to cold air, when they come back from very extremes of temperature into cold temperature. We have solar urticaria. We have aquagenic urticaria, which is not very common though. So we have different tests, and the management remains the same like for chronic urticaria. Here, the response to antihistamines is very good. Usually, we need to tell them to avoid the possible triggers. We also have vibration urticaria, especially somebody is going in bus or vehicles, and if they have kept the hand on a vibrating surface, we would see that hives coming upon those areas as well. Chronic spontaneous urticaria, I think, when it is not inducible, we generally put them, they come into the category of chronic spontaneous urticaria. Here, the triggers are very difficult to be elicited, and it appears unpredictable at any point of the time and spontaneous. That's why spontaneous urticaria and angioedema, here we have at least in 40% of the patients with chronic spontaneous urticaria. Like in hereditary angioedema, where the worry is about the laryngeal edema, here we do not see much of the laryngeal angioedema. And generally here, the course of the chronic spontaneous urticaria is about 2 to 5 years. Most of them, by the end of 1 year, about 60% of them tend to be better. Few of them take about at the end of 5 years, it could be close to about 80%. Another 20% persists beyond 5 years. So when we are counseling the patients with chronic spontaneous urticaria, it is important that we spend enough time with them to explain about the etiopathophysiciology of chronic spontaneous urticaria, and educate them that possibly here triggers wouldn't be much elicited, and the role of skin prick test in the background of chronic spontaneous urticaria is very minimal, and they may need to continue antihistamines for a longer period of time. I think good counseling is the cornerstone of approaching patients with chronic spontaneous urticaria. In chronic urticaria, as we were discussing, there is no much identifiable cause. And more recently, I think we have different plausible explanations like mast cell protein, G-coupled protein receptors, I will be discussing in the next few slides. So this was a very beautiful illustration from one of the review papers which was published few years back, but very beautifully depicts different possible pathogenesis, where this is mainly in respect to the chronic urticaria, where they feel that the mast cell related glycoprotein receptor activation, T cell activation, or physical stimuli, they lead on to the mast cell degranulation and increased recruitment of the mast cells, and more predisposition of the recruitment of eosinophils, and leading on to the release of various mediators, which causes increase in vascular permeability and causing urticaria and angioedema. In chronic spontaneous urticaria, there are two possible hypotheses which is being mooted, where we have autoimmunity or autoreactive IgE. So here the IgG could be an autoantibody against that IgE, which goes on and sits on the high affinity epsilon receptor of the IgE, and then leads on to the cross-linking and then release of the mediators from the mast cell. Or this could be an autoimmunity where we have autoimmune antibodies, especially more important is anti-TPO, anti-thyroid peroxidase antibodies in few of the patients with chronic spontaneous urticaria, which may be the culprit autoantibody, which leads on to the complement activation and then mast cell activation via the complement pathway, which may lead on to the mast cell degranulation and release of various mediators, which can cause this urticaria and angioedema. So, is there any role of any tests in urticaria? In acute urticaria, I think before we go on to offer them any testing, to suggest what should we be offering to do a testing, it's important that we go into a little more detailed clinical history. We should emphasize on the appearance of the lesions like 24 hours, not leaving any residual pigmentation without scarring, with or without angioedema. Is it fleeting in nature? So I think it's important to go into a little more detailed history, see for any pictures or videos if the patient has, and determine whether the patient is fitting into the acute urticaria or the chronic urticaria. And if there are any other systemic involvement, possibly we would be not just dealing with urticaria alone. We should always think about other systemic involvement. If urticaria is there, if it is living across post-residual pigmentation, I think we should keep urticarial vasculitis as one of the differential diagnoses, and that is mainly confirmed by skin biopsy. So based on the triggers, the timing of onset of symptoms, and if the patient has already received any response to the treatment, determines whether we are going ahead with offering a skin prick test or not, how long the patient is happening, the quality of life, especially in patients with chronic spontaneous urticaria or chronic urticaria, the quality of life is very, very poor, and they wouldn't be sleeping, and our antihistamine sometimes would not help also. So I think it is important to spend some detailed time regarding clinical history. We have something called urticaria activity score, where we use this as one of the practical scores to see whether the patient is responding well to antihistamines or how troublesome is the symptoms and if it is very bad. Generally, we take the wheals or the hives and the pruritus into question. We score from 0 to 3 over a period of 7 days and ranging from none to very severe, and 42 is the maximum score which we can give, and based on that we can actually follow the scoring. There is something called urticaria control test also, where we can use one of these are the objective tests, where we can ask the patient to fill it from the beginning of the treatment, how well they have responded as well. It can be a monitoring tool as well. So if the patient is having acute urticaria, we could possibly be thinking of offering them a allergy skin prick test if there is a food trigger or a drug or a stinging insect hypersensitivity where the patient has had those particular triggers and the hives have developed within few minutes to 2 hours, maximum up to 4 hours, and then they could benefit from an allergy skin prick test. Otherwise, if it is a background of history of infection, we would still reassure them and manage them. Only in chronic urticaria, where if the symptoms are being there for a long time, a limited lab testing we could be doing with the CBC, CRP bar ESR. If there is any other symptoms, I would definitely do a baseline TSH and then anti-TPO, especially in females. We see this more autoimmune immunity with anti-TPO being positive, and they respond well to immunosuppressant therapy with cyclosporin. We consider the skin biopsy when we suspect urticarial vasculitis, as was highlighted earlier. The last few slides, I would like to emphasize on the management, which is the most core part. So this is the table which is taken algorithm from one of the position papers, which was updated about 3-4 years back. So mainly, I think the cornerstone of the urticaria management being acute or chronic. Chronic, why I'm emphasizing, because it needs a longer time. Non-sedating second generation antihistamine remains the mainstay of treatment. If required, we increase them up to 4-fold the dose of the normal recommended dose of that particular antihistamine. And if there is inadequate response after 2 to 4 weeks, we would add on omalizumab. And if the patient has autoimmunity or positive anti-TPO or other autoimmune antibodies, we may consider adding cyclosporin. So antihistamine, second generation antihistamines are preferred. The most common we use are cetirizine, levocetirizine, fexofenadine, avastin, loratadine, bilastine. So I think there is no statistical superiority of one molecule over the other. Again, depending on the if the child is having any other comorbid factors, we may choose molecules which do not need any dose regulation in underlying liver diseases or cardiac manifestations or renal diseases. So generally, because we can start with the standard dose and then we can go up to the 4-fold response. Initial effects occurs very dramatically within half an hour, and generally, if you are using it regularly, we can see the full therapeutic benefit with very good resolution or control of the symptoms with persistent use rather than using as and when required. Again, we use validated scores such as Urticaria Activity Score or Urticaria Control Test. I haven't gone much into the other details of other objective assessment in the interest of time. So most of them, at least half of our patients do respond well. If there are poor responders to the standard dose, like poor baseline control where the urticaria activity score has been very less or very severe, we may have to go up to a very high dosage. As we said, until 4-fold the normal dose is better. However, there are no validated biomarkers which can guide the treatment decisions. If the symptoms persist on the standard dose for 2 to 4 weeks, then we would increase it to the standard dose. Generally, the main recommendation is stick to one antihistamine. Do not combine multiple antihistamine. We do not give sedating antihistamine unless it is really bad. And generally, steroid has no much importance in the management of acute urticaria, especially. Chronic urticaria may be a short course, but once we have started them on a good dose of antihistamines, there is no role for any steroid usage. Once the patient is very well controlled, we can reduce by 50% after about 4 weeks, and then we reduce it to the regular standard dose, depending on the patient's symptom control and the relapse of symptoms. If the patient has the relapse of symptoms, we would go back to the last effective dose if the control is last. Omalizumab is indicated in chronic spontaneous urticaria above 12 years of age who remain symptomatic despite H1 antihistamine treatment. Here, it is not curative in nature. It is an anti-IgE monoclonal antibody which binds to the free-floating IgE, not the bound IgE on the mast cells. So It removes the IgE and reduces the threshold for mast cell degranulation. We also published this our case series few years back when we had used omalizumab and continuing to use omalizumab. It gives good response, especially in patients who are symptomatic with a very good dosage of antihistamines and still not responding. There are fewer novel treatment for chronic urticaria where we have an ligilizumab, which is a more potent anti-IgE monoclonal antibodies, which is probably close to getting a clinical approval. We are also having more oral Bruton tyrosine kinase inhibitors also in the pipeline. Okay. So coming back to our case, to wrap it up, the first patient, I think this child had a predominant symptoms of fever, cough, URI, and later developed the hives. I think this could be a post-infection acute urticaria presentation with a good antihistamine dosage. It could be self-resolving, and I think we just need to emphasize that probably this has nothing to do with the drugs which was given, and good antihistamine cover, the patient would be symptomatically better with the resolution of symptoms. Second case, I think this child had symptoms for the last 5 months, fits into the category of chronic spontaneous urticaria. Here, I think we need to re-emphasize that regarding the course of the disease, good dosage of antihistamines and regular follow-up. And here the role of allergy skin prick test is very minimal. And I think clinically, we need to make sure that she is symptomatically better and get good adequate skin care. We would be able to manage her symptoms. So at the outset, in the same sense, before I wrap up my talk, we would like to invite you for our annual Pediatric Allergy and Applied Immunology annual conference, PedAllerCon, 14th PedAllerCon in Bangalore in September 19th and 20th. So we welcome you and look forward to seeing you there. Thank you. And I will be happy to take up questions, if any, now or at the end of the session.
Thank you, madam. You already crossed 100 runs with a strong power play. So that was very captivating and insightful. The message was very powerful. No steroid for acute urticaria and mostly antihistamine for chronic urticaria. So that was very powerful message. One question there in the chat box is Dr. MSV has asked that can you identify bradykinin-mediated angioedema at the onset itself instead of retrospective diagnosis?
Generally, we could, sir. I think it's a conspicuous absence of urticaria most of the times. And because urticaria would be predominantly present and angioedema is not the predominant symptoms in our urticaria presentation, if the patient is only having lip angioedema, eye angioedema, or sometimes they also present with abdominal symptoms also. So I think we could have a high index of suspicion. And even if you give antihistamines for 1 day or 2 days, we wouldn't see much response like in our urticaria patients.
Can I ask Dr. Prasanna some questions?
Yes, sir. Yes, sir. Please, sir.
Madam Soumya, madam, that was a very nice presentation. You made us understand very well about urticaria. In acute urticaria, the minimum duration for which we have to give antihistamines?
So generally, I would give for 2 weeks, sir, initially with a good dosage. And if the patient is well controlled, probably if the patient is on twice daily, I may make it once daily. And if there is still symptoms are not very well controlled, I may continue that for another 2 to 4 weeks. Until 6 weeks, we can definitely give antihistamines, sir.
Okay.
2 to 4 weeks, most of the patients with acute urticaria would require antihistamines.
Okay, madam.
And generally, there is no side effects associated with prolonged use of antihistamines. There has been no reported long-term adverse effects.
You talked about chronic spontaneous urticaria. There are children who have recurrent urticaria. They come back, but there's no triggers we can identify. How do you deal with them, madam?
Sir, I would again put them into chronic spontaneous urticaria only, sir, even if it is recurrent urticaria. And as we were talking, the role of allergy skin prick test in those individuals would be very minimal. And I would definitely do a baseline CBC and just to rule out any other autoimmune markers. And anti-TPO is the most common presentation what we see, but that is more common in adolescent and young adults. So post that if it is negative, I would just put them on a good dose of antihistamines and continue antihistamines at least for 3 months initially before I actually think of stepping down the antihistamines.
Thank you, Dr. Samya.
One more question from Dr. Samyukta, our alumni, DPA alumni. She has asked, should we monitor response to omalizumab with IgE other than clinical improvement?
Good question. I think even when we are starting IgE omalizumab, we only do an baseline IgE only to see that if they are good responders. But otherwise, for monitoring, we do not emphasize the need to repeat total IgE or anti-IgE absolute eosinophil count. It's usually clinical response. In fact, if we monitor also, we would see an increase in IgE and then reduction of the IgE. So we usually do not advocate the usage of total IgE as the marker for the response to the treatment.
Quickly, I'll ask you 2-3 questions, madam. One person has asked about use of hydroxyzine in urticaria. Another person has asked about belastin age cutoff. Another person has asked about topical antihistamine.
Yes, very relevant questions. Generally, hydroxyzine we do not use much at all. I think all of us are comfortable using second generation non-sedating antihistamines because we need to use it for a longer period of time. Given at a good dose, we do see good clinical response. Belastin pediatric cutoff is recommended above 6 years of age, and topical antihistamines generally we do not use. And even contrary, when it comes to topical usage, calamine usage, we do discourage it. I think good skincare, moisturizers, avoid triggers, stress, if any. I think all that matters more with a good dose of second generation antihistamines.
I think the rest of the questions you have answered, madam, already.
Prasanna, if madam will be there, can we take the questions later so that?
Yes, madam, we'll do that.
Thank you, Soumya.
Thank you.
Because a lot of questions are coming up. I will finish the panel also, so it will be easier.
I saw that. Time we may be short for time.
Yeah.
No, you are on time, madam. You are perfectly
on time. You're perfectly on time, but the questions are a lot.
Okay, so now we'll move on to the panel. Please post your questions. We'll discuss at the end. So, as now comes the middle order over, the captain takes over. Dr. Narmada is going to head the panel. Dr. Narmada is a senior pediatrician from Velur, and she has a special expertise in pediatric asthma and allergy and has over 2 decades of clinical experience. She's an alumnus of Diploma Allergy and Asthma conducted by CMC and Colorado University. She has done a PhD from VIT, and she is also a fellow of IAP, RCPCH. She is now under IAP, and she is now the faculty member of all the allergy courses that is happening around India. So she will head the panel, and to be part of the panel, we have Dr. Neeraj Gupta. I think Dr. Neeraj Gupta doesn't need any introduction for anybody here. He's one of the leading authorities in pediatric allergy with additional expertise in pediatric intensive care, pediatric pulmonology, and sleep medicine. He's a senior consultant and faculty in Sri Gangaram Hospital. And it is also the home to designated allergy center. He was the founder director of BPAA. He is the immediate past president of IAP Applied Allergy and Immunology chapter, and he has authored over 100 scientific publications. His H index is around 14. So now he is the founder president of ISAAS, Initiative of Sleep, Asthma and Allergy Sciences. And we also have Dr. Krishnamohan. Dr. Krishnamohan, sir, welcome, sir. He's a distinguished pediatrician from Institute of Maternal and Kozhikode, Kerala, India. He is also underwent specialization in Christian Medical College, and he has been working under Kerala government services for the past 15 years. So he is the previous president of IAP PAA chapter 2024. He is also interested in vaccinology, and he has brought out a lot of books. We also has Dr. Suresh. Dr. Suresh is the pediatric applied allergy immunology chapter secretary, chairperson of Tamil Nadu. Dr. Suresh is one of the leading allergists of Tamil Nadu. He is a consultant in Apollo Children's Hospital. He is a consultant in Kanji Kamakodi Children's Hospital. He is also faculty in all the pediatric allergy courses across India. So with this introduction, Madam, to take over the podium.
Thank you, Prasanna. It's such a pleasure to be in the platform along with Dr. Neeraj, Dr. Krishnamohan, and Dr. Suresh, who have in fact totally changed the way allergy has been looked at in pediatric practice. So without much ado, I'll just go straight into the topic. So we know that 300 million asthmatics across the world, out of which 37.8 million are there in India, which means that the prevalence of asthma is actually looking like it is decreasing, but in fact in India it has been the significant morbidity associated with allergic disorders has actually increased. With more awareness and comes a lot of problems, and parents themselves are very much aware of what is happening. So we are also looking at a very different scenario, that we are right now not getting a food allergy problem so much in Indian scenario, but looking at the serum specific IgE sensitization, it is highest for certain foods compared to many Southeast Asian countries. So we are now standing at a border where we may be going into a food allergy epidemic. There may be an increase with a new set of population that is coming up, that is getting more into a Western style of lifestyle. Their environment is changing. We have more of environmental problem contributing to the allergic disorders. Having said that, if you are looking at the incidence of allergic disorders across the cities, you can see that it is not uniform. Places like New Delhi are having a very high allergic rhinitis, asthma, as well as atopic dermatitis, whereas Chennai, places like Bangalore have a relatively moderate effect. And when we are looking at allergic rhinitis, there is a definite significant increase, not very much looked upon. And when you come to the incidence of the same in 13 to 14 years, you can see asthma and allergic rhinitis are on the increase, and it is very varied. So the prevalence is somewhere for allergic rhinitis going even up to 60 to 70%, and for atopic dermatitis close to about 35% in certain cities. This also decides how we manage the patients, because what we are following in a place like may not be the same which we are practicing in Delhi. Our treatment options, our modalities has to be different. With the extent of many courses across, Dr. Prasanna, can you mute the people? Yeah. Allergic disorders increasing all over India, and we had many courses. We also had the privilege of having so many of our alumnus who are spread across Indian cities. So this led us to having a lot of literature on sensitization pattern across India, and that was a predominantly only a house dust mite or the pollen allergens which has come up. So we also, with PI doing a lot of work, we were also able to find out what are the predominant pollen allergy sensitization there, and we also could understand what is the allergic pattern here. So let's get into the subject of what is more clinically relevant for the pediatric practice, because when 20% of the population have one form of the other allergic disorder, and with the respiratory disorder almost occupying 2/3 of our practice, there is a need for practitioners, pediatricians at the primary level center to be proficient in the management of allergy and asthma. Now, there is an increase in the array of investigations are available, and companies are targeting at the primary health providers, not the allergic persons, in fact, and these are not being standardized for use across here. So, this presentation will actually address the common clinical scenario which a pediatrician or a primary health center person is seeing in their practice. So, I will start with the case one. A 2-year-old has come with the complaints of a persistent running nose which has existed for over a month. Now, he had a viral infection which started in December, and from then on, the running nose has started. The mother says that it is always like I'm coming to some doctor or the other. He has on some days the cough is more, and each episode she says that he is appearing to have a mild fever. Child is growing well, and there is normal weight and height, and he is also has an elder sibling who is going to school. So, Dr. Neeraj, what do you see? Is it a recurrent viral? Are we looking at some sort of an immunodeficiency, or it's an allergic rhinitis? And how do you actually define and how do you approach this in your clinical practice?
Thank you, Dr. Namrata. So, first of all, thank you for the kind invitation for today's forum. And as you have given us this case, 2-year-old child with a family history which is suggestive in another sibling. So that means that there is a history of atopy which is there. This child is also having a recurrent problem which is there. Now, there is a possibility that this child is suffering from allergic rhinitis, because in allergic rhinitis, the sign and symptoms of the child, possible trigger, as well as the previous history and the family history, they all matter. But yes, because this child is 2-year-old and only second episode, and each and every time if it is associated with fever, then we have to also keep a possibility of viral for now, or in the background of atopy, the virus is triggering the reaction. That is also possible. So we need to really understand that what allergy itself is. Allergy itself is classified like a type 1 hypersensitivity reaction, and in which whenever the allergen is coming to a previously sensitized individual, then at that time this allergen is getting attached to the already bound Ig on the mast cell and then producing or triggering the symptoms. So it is also possible that in an atopic individual, even the other irritants, especially the viral infections, can also precipitate the symptoms. And the typical symptoms in allergic rhinitis, these are called as the 4 cardinal manifestations. So these could be like itchy nose, runny nose, blocked nose, and sneezing. So these are the 4 cardinal features which are there. Maybe present 2 or 3 features at a time, but these are the 4 cardinal features which are considered to be.
Okay, Dr. Krishna Mohan, here the mother, when you say the allergic rhinitis, she is not going to approach, immediately accept it. So for her, it looks like a recurrent viral or recurrent, she has also got a fever episode. So she's very worried that something major is happening with the child, and she'll always ask the pediatrician about the same. So how do you really approach it in the first hand?
Thank you, Dr. Narmada, and thank you, IAP and Tamil Nadu chapter and the Tamil Nadu State IAP for giving this wonderful opportunity. So, as Dr. Neeraj has already told, first and foremost thing is detailed history. So, in the history, we have to find out the symptoms, the typical symptoms, the 4 symptoms that Dr. Neeraj already explained. So, we have to see whether the symptoms are occurring. We have to find out the severity, the timing, and how far the symptoms are disturbing the daily life of that patient. Also, especially in allergic rhinitis, we have to think about the comorbid conditions also. The symptoms of the comorbid conditions like allergic conjunctivitis, the obstructive sleep apnea, all those things also we have to take into consideration. The history taking is the most important thing, and it goes like any other pediatric history taking, but certain things are specific for an allergy case, especially the environmental history. Environmental history, like which all triggers are leading to the symptoms, like whether it is a indoor allergen like house dust mite or pollens, or is it an irritant or some very strong irritants like tobacco exposure. So tobacco is a very, very important history that we have to ask. We also need to ask regarding the family history of asthma and allergic rhinitis, of course, and other atopic conditions like atopic dermatitis. we also need to take history about the medications the child is on and how well the child is responding and what all treatment child has received so far. So to begin with, the approach basically is to take a very detailed history and then following a clinical examination. That is how we
Right.
should
So,
start.
having said that, Dr. Krishnamohan, one more question I would like to ask you is like, how do you virus like rhinovirus or RSV infection can itself trigger during this thing? So, do you give more credence to the fever history there?
Yeah, because if it is an infection, even if a common cold, it may be usually associated with a fever. But allergy usually there won't be any fever. So that history is also important.
Okay. So, having said that, how do you really differentiate, Dr. Suresh? So, here you have a viral, maybe a trigger factor, and you have an allergic component added on to it. But the pediatrician, now if you're going to determine it as an allergic rhinitis, you're going to take it in a totally different direction. But it could be also a normal post-viral running nose, which is just he had an episode, a second episode again. So, the mother might be reluctant to, or a parent might be reluctant to start on the management of allergic rhinitis immediately. So, how do you actually differentiate it clinically? He said, Krishnamohan clearly said about the history. How do you differentiate in your clinical practice?
So thank you, Dr. Narmada. See, it's definitely it's a real case scenario what we see in our day-to-day practice. So as Dr. Krishnamohan told, we have to go for a detailed history of the symptoms. That helps us to differentiate this post-viral rhinorrhea, that is almost a rhinosinusitis, from allergic rhinitis. The first important symptom we have to analyze is the sneezing. Actually, sneezing, which is a symptom which is only minimally seen in a patient with a post-viral rhinorrhea or rhinosinusitis, but it characteristically occurs in bouts. Actually, it will be a 10 or 15 episodes of sneezing. Usually happens following any trigger or in the early morning. That is a characteristic symptom for allergic rhinitis. The second important symptom is the itching of the nose. Actually, the itching of the nose is usually a mild symptom in a rhinosinusitis, but in a case of allergic rhinitis, it will be terribly disturbing the child. It will be severe, and not only it is in the nose, it also extends to the eyes as well as the throat. And sometimes we see the children are handling the nose and doing a lot of allergic salute, all these things, even nasal cricases, all these things we can see because of this thing. So these two symptoms are favoring when it is more severe, and it favors allergic rhinitis. And the next important thing is the rhinorrhea, which is thick and purulent in the case of sinusitis or post-viral thing, but in a case of rhinitis, it is an abundant and watery. And already Dr. Krishnamohan told about the family history, which will be, if it is there, it favors an allergic rhinitis. Allergic comorbidities like an asthma history was there in the same child before, it also favors an allergic rhinitis. And systemic symptoms in the form of fever, headache, myalgia favors a rhinosinusitis more than a simple allergic rhinitis. So this history will help us to delineate both.
Yeah, very beautifully put that the sneezing especially continuous அடுக்கு தும்மல் மாதிரி இருக்கு தும்மல்னால அவன் கஷ்டப்படுறானா அதுதான் அந்த terminology அவங்க கரெக்டாக யூஸ் பண்ணுவாங்க when you compare to a viral cold which is going to be prolonged here as well as the itchy which really puts across that it is definitely a typical IgE mediated problem. So Dr. Neeraj, we have been talking a bit, you also alluded upon the sensitizers and triggers. I really want you to differentiate what is a typical sensitizer and you have the trigger factor here.
Thank you, ma'am. So I think this is a very nice question. And actually, so this is some work which we have recently got published, myself and Dr. Somya. We have jointly written it in CEA, and this has been accepted, and it is going to come up, I think, in another 1 week time or so. So what we have tried to see, that we have tried to, you can say, like, categorize the immunological phenomena or the allergic phenomena into an immunological framework. In the immunological framework, there are 3 steps. The first step is the sensitization phase. So in the sensitization phase, whenever the allergen comes for the first time in an predisposed individual or the atopic individual, then at that time, this allergen is having a capacity to, you can say, like, go across the epithelium, get attached to the antigen presenting cell, ultimately shifts the Th naive cell into Th2 cell, and then with the help of certain cells and the plasma cells, and these plasma cells produces IgE antibody. So this is the first phase, which is called as the sensitization phase. Then, though this is the first part of the immunological phenomena or immunological framework, the second part is also called as effector phase. In the effector phase, on re-exposure, when the same allergen comes, then it now get attached to the previously bound 2 Ig molecules on the mast cell, and then it asks the mast cell to release or burst its chemicals. So this is the second phase, which is the effector phase. And in the third phase, the clinical symptoms happen, like the histamine and the leukotrienes and other reactions happen. So clinical symptoms happen. Now, there are 4, you can say, like type of triggers which we often encounter. First is called as primary allergen or true allergen. So true allergen is something which satisfied all the 3 criteria of the immunological framework. That means it is having the ability to sensitize. If you can see, here is a star. And simultaneously, it is also having the ability to act in the effector phase. That means after sensitization, it can act and bind to the bound Ig. And the third thing is that it can produce a clinical symptom. So all the 3 steps it will satisfy. Whereas the cross-reactive allergen will not be able to satisfy the first criteria. So it will not be able to sensitize, but it satisfies 100% second phase. Means in an already sensitized individual, if the cross-reactive allergen, the S depicted here as a circle, so the cross-reactive allergen will come here, get attached to the bound Ig, and ultimately releases the histamine chemical. Now, the third phase, which is the clinical symptom, they can be, you can say, like varying in the cross-reactive allergen. So the cross-reactive allergen, it can variably satisfy the third criteria. So it will satisfy only the second criteria as 100%, but the third criteria will be variably satisfied, will not be 100% satisfied. Then the third factor is called as an irritant. Irritant is something which is neither able to satisfy the first criteria or the second criteria, but what it does is that it actually, you can say, like irritates the mucosa. And when it irritates the mucosa, like if you just see the mark here, the blue mark, and then this irritates the mucosa, and it actually increases the permeability of the mucosa, and hence it increases the clinical symptoms. So what irritant does is that irritant actually satisfies only the third criteria, but not the first and the second. So irritant act through the non-immunological mechanism. And then the fourth factor is called as the adjuvant factor. So adjuvant factor is something which is, you can say, like acting on multiple steps. So isolatedly, it cannot satisfy the first or second criteria, but it is helping all the steps. That means it is helping the allergen entry. It is helping, you can say, like the epithelium barrier defects. It is also helping the B cells to increase the production of IgE, and simultaneously, it is also helping in increasing the clinical symptoms. Now, I will give an examples of these. Like for example, in primary allergen, the common examples of primary allergens could be like dust mite, derpy1, derpy2, something like that, the dust mite allergens. Whereas the cross-reactive allergen could be derpy10, which is tropomycin. Then coming to the irritant. So irritant is the common example is the pollutant, like ozone. So ozone is a common example of an irritant. It can produce clinical symptoms, but it is neither a true allergen or a cross-reactive allergen. And then the example for the adjuvant is another pollutant, which is diesel exhaust particle. So DEP, or the diesel exhaust particle, it can actually breach the mucosa. It can increase the allergen entry. It can increase the IgE production, and it can increase the clinical symptoms. So these are the 4, you can say, like major triggers which can be divided as per the immunological framework. And this actually eases out so many things to understand in the allergy.
Yeah, actually, very simply put, it is like a sensitizer is something that lights the gas so that the tawa gets heated. Once it is heated, even if you're putting a water, it is going to create a problem. So this is what I explained to them, the parents, like that way. It is like there, where so whatever so we need to really find out what lit the gas rather than going after the gas. So this is how we explain. So very, very beautifully put and very beautifully explained. Thank you, Dr. Neeraj. Now, Krishnamohan, the question commonly asked is they will leave everything else, whatever Dr. Neeraj told about smoking or diesel or the environmental. The only thing is he is taking cold substance, or whenever he is taking something cold, even water in our places, they say that he has issues. He drank water yesterday from the refrigerator, or he took the ice and drank, that's why he developed problem. How do you, is it really relevant in the entire context? Maybe we say we have to rely on the mother, so every time she notes it, we have to give credence to it, and we just can't brush it off. How do you say this one?
Yeah, that is a very relevant question. And as you rightly said, it is the most commonly encountered question. I think Dr. Neeraj has already answered the question partly, but still I will take it. So if you ask me whether a cold exposure will increase the allergy or the allergy, we can say that it won't, but will it increase the allergy symptoms? It can. So the basic thing is that it won't affect the allergy mechanism. Dr. Neeraj beautifully explained the IgE-mediated allergic sensitization route. So that pathway is in no way affected by a cold climate, but in some children, at least, there will be a transient increase in the nasal symptoms. That may be due to the mucosal hyperreactivity, and sometimes even the cold stimuli can cause even a bronchospasm, or more importantly, a ciliary dysfunction. So a ciliary dysfunction can also lead to a secondary bacterial or viral other infections also. So in short, the symptoms of allergy may get aggravated, but it is not a true allergic reaction.
So it doesn't start the
Yeah.
process. It actually aggravates what the process has already been started. So that is how
Cold will act like an irritant. In the
irritant.
previous
Yes.
Yes.
Yeah.
the code will act like an irritant. It will not satisfy the first and second criteria,
Criteria.
but the
It will go to
third
the third.
criteria it will cause.
I mean, having said that, 25% of the people who are participating in Winter Olympics have an asthma and they are allowed to take medication. So that itself says we need to give credence, but we need to just tell them that this is not something we have to be worried about. And the other thing, Dr. Suresh, our very common thing is raw fruits. Okay, apple sapta problem and banana sapta. So how do you actually what is it about the history when you're giving a raw fruit?
Yeah. See, all the people, all the pediatricians and all the allergy specialists will agree with us. Actually, most of the parents believe, not only believe, they strongly believe that fruits are the important cause of childhood respiratory allergy. Okay, but actually, in reality, in the literature and in reality, it is not true. And fruits are not at all the cause for the respiratory allergy, and it is not described like that. But the only association which has been described in the literature is a oral allergy syndrome. Actually, here also the fruits are not the primary culprits. They are not the primary allergens. They are cross allergy here actually. So basically the child or the adult who has a pollen allergy or latex allergy, that is a primary allergy. When they are exposed to fruits like apple, apricot, or melons, oranges, and kiwis, or anything like that, they get immediate itching sensation in the mouth, and they may sometimes get even a bad swelling of the mucosa. Also, it happens, and throat also sometimes get irritation actually. So this is a actually cross reaction. Especially it happens when they eat the raw food actually. When it is cooked and or sometimes the skin is peeled, the symptoms will reduce. Another important fruit which is everybody worried is the banana. Basically, the banana irritates
Banana.
me. Yeah,
Yes.
when I take actually, so the mechanism in banana is also not allergy. Basically, it is a histamine release that causes the symptoms. Basically. So we have to explain to them and make them understand that is they are not the real allergens. They cause in a different way the symptoms. So they are not be the real cause. They are actually, as Sir is telling, Dr. Neeraj Sir is telling, it is maybe an irritant or something like that.
Yeah, so cross reactivity happens because of the pollens, and quite commonly we have one of the patient got me an apple, different type of an apple, which was going in the hill station of Elagiri. And then when I went into the details, that the cross reactivity was more with the birch pollen sensitization here.
Yeah,
And we have a lot of our children very sensitive to prosopis and parthenium. The incidence in Vellore was almost equivalent to that of the dust mite. So when they develop cross reactivity to any of those, they are going to develop reaction to fruits also. And one more, yellow banana has got a high histaminergic content that could contribute. Very beautifully explained, Dr. Suresh. So mother also says, Doctor, that he is not sleeping well at night, and he's got this daytime somnolence, like he sleeps into the day. So any issues here, Dr. Neeraj?
Yes, definitely. So we need to really understand that how this child or the family is getting bothered. For a particular child, the quality of life measures is like school absenteeism, how is his sleep, which is affected, and how his daytime, whether he feels sleepy or not. So how his education is affected, and then later on, his overall growth is actually getting affected. So we need to really take value to this, and this seems to be, yes, definitely affected. His quality of life and sleep is getting affected. We need to take a little more detailed history about snoring, about mouth breathing, and there is a possibility that with this allergic rhinitis problem, there might be some adenoidal hypertrophy, and which actually is creating some sleep apnea or obstructive sleep apnea type of a problem. And we need to really assess it by polysomnography and then move forward for rectifying.
Yeah, when I asked her, she was telling that he was snoring, so I asked her to get the video of it, and this was the video we had.
Yes.
So,
It seems that this is definitely some sort of airway obstruction which is happening, and with the history of allergic rhinitis, adenoid hypertrophy will be the first thing which will be kept in mind.
yeah. So, having seen this, this is definitely an obstructive sleep apnea symptoms. So, will you take it differently, or how do you approach this problem?
So, as we
Dr. Neeraj,
discussed
you can
earlier,
take it.
yes, as we discussed earlier, we need to really understand that there are two aspects of any allergic management. One is the symptomatic management, another is the etiological management. So, for the symptomatic management, we need to really do something which can improve the quality of the life for that particular child for now. His symptoms should be improved, right? So, for this particular child, for symptoms to be improved, we need to, you can say, like start him on some intranasal corticosteroid sprays, and we need to also try to see that how much this obstructive sleep apnea, up till how much grade in terms of apnea hypopnea index which is happening with the help of the polysomnography. If it is coming in like a severe grade, probably AHI more than 10, then at that time even adenoidectomy at that stage will also be helpful. But if it is coming somewhere like less than 5, then definitely we can continue with intranasal corticosteroids. And if it is in between 5 to 10, then we need to really see that the effect on quality of life of the child or the parents, and then we need to follow the child accordingly with that. The other thing is that simultaneously we need to also work up for the etiological agent, that what is actually bothering, what is the trigger, or which allergen is the child is suffering from, and then that particular allergen, if we are
Yeah,
able to, okay, yeah, so we can discuss later on. But yes,
we'll go to
that
that as we discuss further. But
yeah,
the main problem here is looking at isolatedly, we should not look only at allergic rhinitis. We need to look into the comorbid features, and that is predominantly snoring, which is missed, which is contributing that is to the thing, and otitis media, and all of you have alluded upon to the asthma, which is coexisting, because they would not come and tell to us about the conjunctivitis, right? They will think that it is a ophthalmic problem, and the noise that is coming in the nose is a nasal ENT problem. So we need to definitely, yeah. So we need to ask about that continuously. So this was a study which I did, and when we looked into the asthma, I was actually looking into the asthma, but I find that there was a significantly higher percentage of recurrent otitis media and adenoids, and this is one of the literature that was published in International Journal of Otolaryngology. Okay, so then we come to the context of a united airway disease. Dr. Krishnamurthy, can you explain a little bit about this before we go further to this one?
Yeah, so United Airways concept is not at all a newer concept. So it basically means to say that our nose and respiratory tract, they are not two separate entities, and they are very closely related. So whatever pathology which is occurring in the nose will be having an effect on the lower respiratory tract and vice versa also. So that is not only the symptoms, the treatment also. If you're giving a treatment for your allergic rhinitis with the intranasal steroids, that is also having an effect on your asthma also. So that is what this is basically about.
So sometimes when the allergic rhinitis is not getting controlled, or your asthma is not getting controlled, we
Yeah.
really need to look into the other place where we have missed. And most of these children do have an evidence of this particular patient had a little bit of speech delay which was started to come, and that was because of the otitis media which was hidden. So having said that, Krishnamurthy, how do you actually find the cause for such a disease? We just Dr. Neeraj was about to tell that. So
Yeah.
let us go into this.
Neeraj detailed regarding the basic mechanism of allergy, where he told about the IgE mediated mechanism and the sensitization. So when we are looking for the triggers, especially for the allergens, what we are looking for is for the sensitization. We are not looking for the allergy. So when we do the different tests, let it be an in vivo testing or the in vitro testing, what we can confidently say is that whether the patient is sensitized to that particular allergen. So in vivo testing, where we are doing directly on the patient, we can do the most commonly used one, which is the skin prick test. As you can see in that picture, we can use different allergens and give a prick so that we are introducing that particular allergen through the skin onto the top of the mast cell, and we are creating a allergic like reaction where we will be getting a wheel reaction, And if it is positive, we can say that that particular patient is sensitized to that allergen. So that is regarding the in vivo testing, skin prick testing. We also have the in vitro testing, like the most commonly used one is the immunocap. So there are certain situations where we cannot do the skin prick test. The typical example is when you are getting a moderate to severe atopic dermatitis, the skin is compromised, there you cannot do. If the patient is having urticaria, severe urticaria and dermatographism, there also you cannot do. And if the doctor or the technician is not at all trained in SPT, there also you have to go the in vitro testing. And another situation, even though we say that we can do a skin prick testing as young as 6 months, but practically when it comes to a child, even the parents will be very apprehensive of doing multiple pricks on the patient. So there also you have to go for a in vitro testing. And we discussed about the oral allergy syndrome.
Hello, K.
Advanced one like result testing and distinguish between a true reaction and a cross reactivity. So these are certain situations where you have to do a in vitro testing. So that is all.
Yeah, I think that is more relevant for the audience today because they training to the allergy skin testing does require you to undergo some training process, and you will not get this sample. And more relevant is your serum specific IgE, and lots of labs are actually giving that, right, as to the practitioners. Dr. Can you say which are the panels they will have to use, and you have panels that are existing for some 2,000 rupees, you get a foot panel or you get the allergen panel. And then there are testing that even one single allergen is going to cost you about 600 rupees too. So, and can you elaborate a bit about this, and what is the panel which is more clinically relevant for them to choose in their practice?
See, this is a common problem actually we see in the allergy practice. They come with a lot of allergy blood tests also. So the point I want to highlight is we have in vivo test, which is a skin prick test. Dr. Krishna Mohan has already discussed, which is the gold standard. There is no doubt about it. The alternative is the in vivo test, the serum specific test. Regarding the serum specific IgE testing, initially it was started with the RAS test actually, and then it progressed to ELISA. So these are all outdated now. Nowadays there is no RAS and no ELISA test actually, because there is a lot of false positives, all these things. So in the current scenario, the choice of serum specific IgE testing is only immunocaps, which Dr. Krishnamohan has already mentioned. The immunocaps are good tests, and they can be used in identifying only sensitization. It is not allergy diagnosis. It can be used in children with respiratory allergies, particularly of dust mite allergy. But there also, suppose you want to go for an immunotherapy, again allergy skin prick test is very, very important. Diagnosis can be supported by the immunocaps, but skin prick test is the gold standard test that is very, very important. And another point is I want here to highlight is they are all expensive tests actually. If by mistake a lot of by doing a lot of things, you can make the patient more expensive than compared to the skin prick test. So panels, regarding the panels of immunocaps, there is no specific panels recommended by any guidelines actually. For respiratory allergies, one can use immunocap, particularly involving the dust mites and the cockroach in a younger age group. In an older age group, we can add some pollens also based on the areas where it is prevalent. Actually, we can use it off. The more important point I want to do the don'ts with the serum specific IgE is, as Dr. Narmada is telling, we see a lot of IgG based test actually. There were many patients do for a lot of things for IgG based test. Actually, what problems we are seeing with allergic rhinitis, wheeze, asthma, all these things are IgE mediated problem. By doing IgG mediated test, it is not at all useful for diagnosing respiratory allergies, all these things. So it is not recommended at all. The one more recent advances I want to highlight is a component resolve diagnosis, which is a very expensive test, and it should not be used just like that. It should be used only with the involvement of the allergy specialist, which will definitely help in the identification of the allergy.
Yeah. So the final message is don't use the panels which are very with it comes like a allergen panel or a food allergy panel. You will have to know the sensitization pattern. That is why we alluded upon what was sensitization and get your panels very correctly. And component resolved diagnostics has got more to do with the molecular allergologist who have a very good idea of what is the proteins they are dealing with, and it is best left to the allergy persons. Now, having said that, Dr. Neeraj, there are a lot of practitioners who do the total IgE. And Soumya, there was also a question about total IgE used in Urticaria also. Do you think it is clinically relevant? See, when a patient comes and he feels that something is really bad with the child, they want you to do some investigations, and I quite often see the total IgE, and people say that I have eosinophilia and come with the CBC disorder. So what do you comment on this?
So from the allergy practice point of view, total IgE itself should not be used as a first test or a screening test, because it is having so many false positives and so many false negatives. First of all, let's talk about false positives. So total IgE is something which is getting affected by a lot many factors, especially in our country where gut parasite is the most common problem. Then pollution itself, viral infections, COVID, post-COVID, Epstein-Barr virus, influenza, so many different reasons, tuberculosis, so, and then malignancies also. So total IgE is totally a non-specific test. It should not be done. And we do not have really the normograms for our country for what should be the total IgE for our countrymen. So that is why total IgE is not the test for any screening test for our people. So it should not be done. And similarly, even if the total IgE is normal, then also allergy is possible. So total IgE is not helpful. It is helpful only in selected situations. Like for example, if you want to treat someone with, like for example, ABPA, and you want to calculate the dose of omalizumab, then at that particular time, total IgE might be helpful. If a history which is probably depicting you somewhere hyper IgE syndrome, and you are really thinking that total IgE is somewhere around 40,000, 50,000, 80,000 or lakhs, then at that time it might be helpful, but otherwise not. Regarding this autoimmune versus autoallergic urticaria, and the total IgE, when we are saying the total IgE high, then we think that it is auto-allergic, and total IgE normal, then when we feel it is autoimmune. So these are from the Western guidelines, and we really don't know whether they directly apply to us or not, because in our country, we really don't know that what is the normogram for our people for total IgE. So we need to really understand in between the lines that what we want to say, that guidelines say about autoimmune, autoallergic, but does it really apply to us? Can we really use this yardstick of total IgE? I probably think that that is not the right yardstick for us.
Yes, so maybe we will take it totally into consideration. And as you rightly pointed out, there are different normograms. I see people bringing up with 800 international units and saying that it was a doctor told it is an allergic disorder. So we'll have to think about the values. Usually we don't go by that, and we are looking at somewhere thousands if it is applicable in certain situation, as you already
Nowadays,
said.
what is happening
So
now?
having said that, Dr. Krishna.
Dr. Narmada, nowadays what is happening that
Yeah.
the insurance panels, many times the people are including total
Mm.
IgE in the insurance panels, and then they get some funny number
Yes.
somewhere 300, 400, and before that they were actually doing well.
Yes.
They were not ill. They have just
Mm.
got a panel and in which a little IgE was high, and now they try to chase the IgE with the second report and third report and fourth report,
Yes.
and they are just chasing the numbers. And then thereafter they seek for some anti-IgE injections, which are not omalizumab, which are probably some other injections which are taken for months together, and for what we really don't know, because they were not symptomatic at all. There were no symptoms.
Yeah, very true, Dr. Krishnamohan, Dr. Neeraj. Whenever I get the patient, they'll say, I got eosinophilia. And when we are having a and you look at total IgE, it will be about 800. But this total IgE as most abused like a Montelukast. So, and when you get some 800 to 900 and you know it is going to be normal for this population, it's very difficult for us to explain. And they will be thinking forever that they are allergic. And as you rightly said, they will not take the right treatment. They are asymptomatic. So they will go behind something else. Very beautifully said. Then having come to the treatment we started off, Dr. Krishnamohan, how do you think you're going to treat these patients?
So the treatment is like any other allergic disease. The first and foremost thing is allergen avoidance. So we have to, having found which is the sensitizer or which is the trigger or irritant, we should take all steps to avoid that particular allergen. And rest of the pharmacotherapy depends on how ill the patient is. That is, we have to follow the area guidelines and see whether the patient is mild, moderate, or severe, intermittent, or persistent. And beyond that, if it is a mild case, we can start with the oral antihistamines. Oral antihistamines, what is recommended is the non-sedating second generation oral antihistamines. And if the patient is not responding, the next most important drug is the intranasal corticosteroid. So the INS is the most important drug in allergic rhinitis, and it is the most effective drug in all symptoms. Or let it be itching, sneezing, or rhinorrhea, congestion, whatever it is, the intranasal corticosteroid is the most effective drug. And suppose the patient is not responding to the intranasal corticosteroid alone, sometimes we have to combine with it with the topical we have to consider allergen immunotherapy also. Now we have the standardized allergens in India like the Sensimmune, so that also can be considered. And we have to remember, just like asthma, we have the step up and step down. If the symptoms are poorly controlled, we need to step up, and the symptoms are not well controlled, we have to step down. And
Yes.
regarding the intranasal corticosteroids, as you can see in that picture, it depends upon the percentage of systemic bioavailability, which intranasal steroid. So we have to use the one with the least systemic bioavailability so as to avoid the side effects. So as you can see in that picture, we can use mometasone, we can use fluticasone, both furoate and propionate.
Yeah, so mometasone is much safer in children less than
Yes.
6 years of age, and fluticasone is more over the 6 years of age. But having said that, Dr. Suresh, there has been a recent change in the guidelines that has come up with the thing. And can you elaborate on this, because that has got a lot of clinical relevance for the practitioners?
So, Dr. Narmada, this is a good IAP guidelines actually. It is ARIA IAP guidelines which is published in 2025, which specifically focuses on the usage of intranasal treatment actually. In asthma, we are all very clear about inhaled corticosteroids. This is about the international steroids and the intranasal antihistamine treatment. So what, as a practicing pediatrician or allergy specialist, what we should know is the first line choice of usage of intranasal steroid is recommended as per the guideline is the fluticasone furoate or the fluticasone propionate. And if you are using the monotherapy and you are not getting enough response, you can add on with this with the intranasal antihistamines, which is an azilacin, which is recommended rather than olopatadine actually. So this is a newer thing actually. So the combination of intranasal antihistamines with intranasal corticosteroids can be used if monotherapy of intranasal corticosteroids is not beneficial. But very important is when you are using a monotherapy, always if there is no response, rather than jumping to adding antihistamines, what is the practical thing is check the technique of intranasal nasal spray, then go for it. And another important thing is avoid the decongestants. The common thing which we use in our day-to-day practice, ephedrine should be avoided as far as possible. It should not be recommended at all, and xylometacirin also should be avoided as far as possible. It is recommended only about 12 years of age for a period of up to 5 days of nose block, and it is also avoided in the pregnancy as well as in the elderly age group.
So instead of jumping into intranasal steroid, because very often they will come, immediately you start intranasal steroid, they will say the symptoms have not come down. So better to use supportive oral antihistamine for some time, or combine it with an intranasal antihistamine if you are very clear that all the techniques, everything has been taken care, and the environment. And having said that, this is what the guidelines, you have to use a combination, either using azilacin fluticasone or olaptadine with mometasone. Olaptadine is not very much used in Indian scenario here. So what about the most abused or most used drug, Montelukast? I wouldn't say abused, most used drug, because Dr. Neeraj, it's going like you combine antibiotic, then you see Montelukast, levocetirizine, and pediatricians want to be safe that they're not using any cold combination. I've just seen a really increase in the usage of Montelukast, levocetirizine. What is your take on it?
This is actually my favorite question. I always love this question. So this is something which we need to really understand. 2-3 things. First of all, Montelukast is not a drug which to be used for acute conditions, whereas antihistaminics like cetirizine or so, they are usually used for alleviation of acute symptoms. That means there is no clinical indication which demands combination of Montelukast along with antihistamine. So this is first point. Second point is that one of them is alkaline in nature and one is acidic in nature. You cannot really combine two different property drugs, one alkali, one acid, in one matrix tablet or one syrup, because that ultimately they will, you can say, like neutralize the effect of each other or reduce the availability or potency of each other. So this is not done. If because of some reason somebody has to make a formulation, then at that particular time it has to be in a bilayer tablet. That means they need to be separated by a intermittent layer, in which on the one side there could be montelukast, on the other side it could be antihistamine, and then only it can be the correct pharmacological product. And the third reason which I want to say is that right now currently from all the guidelines, whether it is dealing with asthma, whether it is with allergic rhinitis, whether it is with your chronic urticaria, montelukast is not used as a first line drug. In allergic rhinitis and in asthma, it is now considered as a second line add on drug. If the patient is not responding, then only. So the bottom line is that montelukast is now going out and out, and no combination drugs for levocetirizine or for any other, you can say, like antihistamine along with montelukast.
Okay, so I think with this we have a final question on the allergic rhinitis. Dr. Krishnamon, can you say for safe antihistamines which can be used for a little prolonged time in case of allergic rhinitis?
Yeah, so antihistamines, as I already told, it can be oral as well as topical. So the topical ones, the acetylstin and rolaperidine. So the advantage is the fast action. Even if you are starting an intranasal corticosteroid, it will take some time to act. Whereas a antihistamine, if it is used topically, it will. So for the very severe cases, who is having very symptomatic, you can start a combination of intranasal corticosteroid and an antihistamine. Considering the oral antihistamines, you can use the non-sedating second generation antihistamines like cetirizine, loratadine, levocetirizine, and the recent ones like bilastine. Bilastine is a very good antihistamine. With the advantage is that it is not at all having sedation.
And it's a once a day dosage also, so very convenient.
Once a day.
So for allergic rhinitis, so it's a very allergic rhinitis were a very important problem, under recognized and under treated. That's why we wanted to take this as a major thing. We'll be shifting gears and going on to the other allergic disorders. We are not going to touch on asthma because we have a separate module itself for that. But because of there are a lot of questions coming up, so we will go ahead and take up the other things in the faster way. So I'm going to just ask about the second case, 8 months old baby who came with the complaints of irritable cry and inability to sleep. Mother has noticed that there is a change in behavior after the appearance of the rash in the face and body. Our child was already playing well and all that has started being very irritable. And mother also says that she has recently started on cow's milk. She was on exclusive breastfeed and this was the time of the weaning. Father has got a non-history of asthma and she is saying that she has been using only the baby soap and one product which everybody uses and the moisturizer. We have the fancy products that comes in the internet, so she has been using all that and she became very angry when I told that was now it had got perfume and it is not to be used because it was a very costly product. So Dr. Suresh, you get the questions right. Is this the reason for irritability? Has the change of the milk contributed? What is the soap and will it produce a problem? So what do you think about it, Dr. Suresh? Is this the reason for the irritability?
The infant we have described just now looks like actually suffer from severe eczema actually. This 8-month infant suffer from eczema. The basic problem here is the intense irritability. Intense irritability results from the pruritus. Actually, the basic problem here is the pruritus because of the redness and the itching. And the pruritus is so severe and it makes a child to get disturbable sleep actually, and this is responsible for the irritability. So the main culprit here is the pruritus, and the problem what we get is a chronic relapsing skin lesion, which commonly involves the face and the extensor aspects. In the older children, it presents the flexor areas.
So definitely it's a case of an atopic dermatitis, we all know, and then the irritability, as you rightly said, has been by the thing. But then you have the infantile atopic dermatitis, you have the adult also. There are a lot of changes with regard to where it comes, and so we have to be very clean finding out where it is there. But the other question from the mother is the milk the reason for this? So Dr. Neeraj, this is a very common thing because whenever you say anything, they will relate it to the food.
Yeah, I understand. So we need to really see and take the history here. So 8 months old child started having this problem, recently introduced with the cow's milk. So we have to keep one, and the family history of allergy is also there. So there is a possibility of milk protein allergy also to be kept here. And at that particular time, we need to really check that whether this particular element is also troubling. So we need to do certain testing. If the skin is allowing us, then skin prick test will be the best. If the skin is not that healthy or we cannot stop antihistaminic, then specific IG will be used by Benocap. And if it is positive, then simultaneously we should also check for soya also, that whether there is any 15 to 20% chances are there that they might also react to soya. If the soya they are not reacting, then we can shift the child to the soya milk and see that how the things are happening. But the most important thing which we need to understand is that even in case of the food allergy, especially in this child like eczema, so it is not the food which is the first culprit. It is basically the epithelial barrier defect, which is the first culprit, and through which the food actually translocates, and ultimately the food allergy potentiates, or food potentiates the already existing epithelial barrier defect, and then it creates a problem. So that understanding helps us in management of that also, that a good epithelial barrier, you can say like moisturizer or cream, which is the need, which will be helpful in the management of the child.
Yeah, so one more thing is 40% of the children who have a cow's milk protein allergy also do have a soy milk protein allergy, right? So that is one of the conditions we need to take. And then sometimes they will ask whether I can give a formula milk or a goat milk or some other species milk. Even sometimes they ask even the donkey's milk. So you'll have to tell that if you are going to be sensitized, it is across the thing. And as you rightly said, serum specific IG will definitely help us. And it has to be given credence to the change of the milk which has happened. Probably an avoidance for some time will definitely help, and then reintroduction, if it's going to be flare up, we can definitely clinically know that it is because of your milk. Okay, having said that, Dr. Krishnamohan, we all know that you're very an expert with managing this condition. How do you really manage in your clinical scenario?
So, just like asthma, nowadays, the current understanding of atopic dermatitis, the pathogenesis and all, it is that it is almost like asthma. It is an umbrella term. Atopic dermatitis is not a single disease. So, in a genetically predisposed child who is having a favorable environment with all those allergens and all, he will start getting the symptoms. And as Dr. Neeraj Gupta told, there is an abnormal immune response, which is a Th2 skewing, and along with that, there is an impaired barrier function in the skin. There can be underlying mutations. Most common one is the filaggrin gene mutation. And basically, what I would like to convey is that atopic dermatitis is no more a single disease. There is a phenotypic heterogeneity. Having said that, the management, even though it is a very broad term and it is having a lot of phenotypes and all, the management to start with is almost the same. The basic principles are the same. First and foremost thing is that ensure the correct diagnosis. You have to rule out the differential diagnosis. There can be a lot of differential diagnosis, including immunodeficiency and malignancy. So you have to rule out all those things. Second thing is that once you have identified, you have to give a proper education to the parent as well as to the patient. Counseling is very, very important. Nowadays, we use the term therapeutic counseling. It is considered as part of the treatment. And just like for any other allergic disease, we have to take the steps for allergen avoidance, trigger avoidance. So whatever is causing the irritation is leading to the itching, we have to avoid, especially the dressing. Suppose the child is using a non-cotton dress, we have to correct that. And the materials the child is using, the toys that you, all those things are important. And ensure the proper medications and adherence to the treatment. So the basic pathophysiology here is a dryness. So we want to moisturize. So a proper use of a moisturizer or an emollient is the more important thing. So sometimes what is seen in our clinical practice is we advise them to use a moisturizer. They will be using it once in a while. But we have to reinsure the fact that you have to use it frequently, at least 3 times a day. You have to use it, and the how to use it and also the we can discuss it later. So that is the most important.
Even they will ask starting from the bathing also. Now there's a very common practice now to put a very hot water on the baby so it will sleep well. That's a very common thing in Tamil Nadu, that you bathe the baby very well in hot water. Actually, the baby will cry, get exhausted, but they feel it gives a good sleep. So Dr. Suresh, and so they nowadays with Gen Z, they want to be very clear. You say something about bathing, they want to know how to bath and everything. So how do you give the clear instructions to them?
So as you say that the normal children, they give the hot water bath, but whenever patient sees a eczema child who has a very red skin and lot of lesions are there. They are many times they are afraid to give bath actually. So they give bath only 4 days, 5 days once also. That also we see in a reverse also happens sometimes. So what is the recommendation is the children definitely should be given a daily bath. That is very, very important, at least once. And the water should be, as you specified, it's very, very clear. It's not a hot water bath or neither hot water bath nor a very cold water bath. It should be a lukewarm water, preferably around 27 to 30 degrees Celsius, and for a short span of time, around 5 to 10 minutes. And more important is, as Dr. Krishnamohan told, very important is soon after the bath, you just do some tepid sponging and remove the thing and apply the moisturizer. That is a very important thing they have to do it. And regarding the soap, non-irritating, non-fragrant soap is very important with a low pH. That helps the child to improve the symptoms in a much better way.
Okay, so what is the exact moisturizer? You have various kind of thing, and there are YouTube influencers who tell that a particular product is an organic one, and many things they are claiming. So what do you say, Dr. Neeraj, to those patients?
We need to really understand that there are different categories of moisturizer. Sometimes it is called as humectant, emollients, and different other names. So, but the main purpose is that as Dr. Suresh was mentioning, that whenever a child is getting, you can say like bathing, then at that time, for keeping the child in water for 5 to 10 minutes during the time of bathing, so that particular time the skin get some moisturizer. And now our purpose is that we want to keep that moisturizer trapped inside the skin layer, in the epidermal layer. And that is why there are certain occlusive agents which are actually helpful, which can actually trap that particular water and they reduce the transepidermal water loss. Then there are certain humectants which actually you can say like absorb the water from the deeper layers of the dermis and ultimately they give it to the epidermis. And then there are certain emollients which are actually also helping by certain natural lipids. So what I want to say is that an ideal moisturizer should be able to, the property should be that it should be able to retain or keep the skin moisturizer intact. It should be able to withdraw the moisture from the deeper dermis layer and give it back to the epidermis, and simultaneously it can also stimulate or potentiate the natural ceramide production, which is more helpful. So these are the properties which are needed.
Very good, very well explained, Dr. Neeraj. But Dr. Krishnamon, you were alluding some to the point that how do we apply it? You said it should be applied 1 or 2 times a day. It should not be applied. It should be applied multiple times. How do you exactly tell them?
Yeah. So this is all part of the counseling that I mentioned, because this is not about the drug alone, how you use that. So you have to tell the patient to when to apply the moisturizer. So ideally it has to be applied within 3 minutes of bathing. When the moisture is still there, you have to apply that. And as Dr. Neeraj was mentioning, it should be ideally fragrance and dye free. It is very difficult to get that such an ideal product, but still you have to go for that. And you have to prevent contamination by using a clean spoon or spatula rather than using your own hands to take the emollient from the container. So you have to soften the moisturizer by rubbing it between your hands and then apply it to your body using a palm in downward stroke. So that direction also is important, because that is the direction of the hair growth. So otherwise, if you are using it in the opposite direction, it can lead to folliculitis. You have to remember, atopic dermatitis is one condition which predisposes very strongly to staphylococcal infections and viral infections, viral skin infections also. So you have to be very careful with that. So avoid rubbing the moisturizer. You just have to gently apply it in the downward direction and within 15 minutes.
I have 2 more things to add. What about the oils which has to be used before and oils later? Anything like, because we have the practice of
oil can also
oil
can also be used. It is not a big no. If for the patient who cannot afford the costly moisturizer cream, you can use an oil. You can use coconut oil. You can use sunflower oil. But oils like olive oil is not at all recommended. It can itself act as an irritant.
Okay, thank you so much. So can I use some oral medicines to stop her crying, Dr. Suresh? That's because she has been irritable, mother has not had a good sleep.
So actually, with reference to the oral antihistamines in eczema, international recommendations, including NICE guidelines, recommends that there is no routine use of antihistamines to stop the irritability or make the child stop crying. but there is a small space is there to use antihistamines, especially when the sleep is disturbed. It can be used for a short duration of 1 to 2 weeks. It can be used. More importantly, we should know is why antihistamine should not be used. That is very important. See, basically, we all see urticarias where we give antihistamine, because in urticarias, mast cells are the main culprit and they release the histamine. So histamine is the mediator responsible for the itching in urticarias. So you give antihistamines, automatically there is a good response will be there. In contrast, in eczema, the main cause for the pruritus is because of the dry skin as well as the barrier breach. This triggers chronic inflammation. So which causes the release of substance P, and through a cascade of events, it causes the itching by non-histamine mediated mechanisms rather than the histamine mediated mechanism. So the basic cause is not histamine here in eczema. So even you give histamines, you may not get enough response. So unless sleep disturbance is there, routine use is not recommended in the guidelines and recommendations.
Yeah, you're giving a sedative antihistamine. Child is not able to sleep because of the irritability. Both will make the child still more irritable. So you need to tackle the basic cause. So a quick look on to the latest management, Dr. Neeraj, and then we'll go on to a rapid fire question.
Yes.
What is your take on this latest management of?
Yes.
Yeah, he's there. He's there.
Yes, definitely. So suppose if the child is not getting adequate response to the topical steroids, or if the child is steroid, I will say steroid dependent. That means as soon as you are giving steroid, the child is becoming better. But once you are stopping the steroid, the lesions are coming back. Then at that time, we definitely require some steroid sparing agents. And in that condition, topical calcineurin inhibitors will be the drug of choice in that condition.
Okay. Thank you. We'll go for a rapid fire for the last case so that we will have time for a discussion here. I'm just kicking off the last case. So this is one child who came with a 10-month-old male child who presented with a rash. She had fever for 3 days and has given amoxicillin by herself. And the mother noticed the rash has come. So what are the possibilities here, Dr. Suresh?
So the two possibilities or three possibilities is, first is the most important, is viral exanthem. Child had some viral illness. Child had recently taken amoxicillin and had a rashes like a measles illness, and the third day of rash fever, child had a rash. That is one possibility. Second is a drug-induced rash, amoxicillin triggered rash. This is quite possible. It can trigger an acute urticaria, or it could be cause a macular rash, which can happen even little later also after stopping the amoxicillin also. The third combination is very important, is the combination of virus as well as the amoxicillin. Here it is very commonly seen in EBV actually. So when EBV infection is there and you give amoxicillin, there is a very high probability of around 80 to 100% of getting a rashes. So one of the three possibilities I would like to think in this patient.
Yeah, but very difficult to manage. Now, Dr. Neeraj, how do you actually clinically tackle this? And it will be worse if you are the person who had given amoxicillin in your practice.
Yes, I understand. So as you mentioned that this seems to be some sort of fever, as well as the child has got some amoxicillin. So we need to really see that is the antibiotic really warranted. If the fever is purely viral, the other inflammatory markers are negative, then at that time I would like to stop amoxicillin for that particular child and just to continue with the antipyretic management and the other medications. If suppose the other anti-inflammatory markers are positive, or the child is sick or toxic, then at that particular time I would like to change amoxicillin to probably another different group of antibiotic. For now, I'm not labeling as it amoxicillin allergic, but I'm changing the amoxicillin for now to some another group, and then to treat the child. And once the child is well, then thereafter we will once again see that can we delabel amoxicillin allergy in this particular child.
Yeah, the delabeling is so very important because amoxicillin is a very commonly used drug in for us, and this mother will usually generally they will be saying that we are avoiding the amoxicillin in the future. These are the 4 possible scenarios that can come, and they will. And the thing is, we need to tell them that it is not due to the amoxicillin here. So, but if you feel that it was definitely due to the amoxicillin, how do you approach this, Dr. Krishnamohan? And how do you really confirm this?
So here also we have to see the history. The history should be very proper, and we have to see what were the initial symptoms were. Here in this case, the symptoms are only mild cutaneous reactions, and it is not like any systemic reactions like anaphylaxis. So you can consider, as Dr. Neeraj was telling, you can consider another group of drug, or even cephalosporins may be considered because it is unlikely to be a type 1 reaction. So even cephalosporins can be used. And further, we can do the testing of the particular drug, but it is not freely available in many places. We have to get the non-irritating concentration of particular drug.
Yeah. So the thing is that if it's going to be IgE mediated, as soon as the drug is being given, within 2 or 3 hours, the child is going to develop a reaction. So in that way, we know it's a type 1. And the presence of any anaphylaxis or so, then we know we have to avoid the complete antibiotics with the beta-lactam ring. That is why we are avoiding the cephalosporin, because the most common irritant here is the beta-lactam ring here. But if it is not a type 1 reaction, as in this case, very told, Krishnamon has told, you can give the cephalosporins itself here. For this particular episode, if it warrants an antibiotic, and probably go ahead for the you have to actually do for, if you're very clear that it was not the drug, an oral drug challenge in your clinic in a very controlled atmosphere, so that the mother starts giving the amoxicillin later also. Otherwise, avoiding that simple drug can lead on to a lot of problem later in life. Okay, so this one is an expected reaction, and even if it is going to be due to amoxicillin, it was a skin reaction. But there are certain conditions which can produce a very severe reaction, that's like a severe cutaneous drug reaction. So Dr. Suresh, can you tell a little bit about this lesion?
So see, the scar, which is severe cutaneous drug reaction, which is the severe, unpredictable, life-threatening reactions, commonly occurs with two entities. That is a DRESS syndrome, which we used to tell toxic epidermal or Stevens-Johnson syndrome, where actually in DRESS syndrome, the children, when exposed to the common drugs like phenytoin or even to antibiotic like vancomycin, after 8 weeks or 12 weeks later, they develop a severe reaction with a high fever, lymphadenopathy, systemic manifestations, including multiple organ damage. Similarly, one more thing is a staphylococcal scalded skin syndrome, where the children gets, it's a toxin mediated, staph toxin mediated reaction. They get a diffuse erythema with peeling of skin, where you have to give the hydration and the antibiotics will help the child. These are the common things. The toxic epidermal is also a mucocutaneous involvement with serious morbidity and mortality, where Stevens-Johnson syndrome is there, and more severe form is the toxic epidermal.
Yeah, so the severe cutaneous adverse reaction can affect all the parts of it, but the thing is that the mucocutaneous involvement really goes more in favor of the staphylococcal infection. Less than 10% involvement, suspect a triple S, but if it's more than 10% of the skin involvement, go for toxic epidermal necrolysis. But when you see the mucosal reaction, I think we'd have to be really very careful about this, and here you're dealing with something more sinister. It is better to be managed in a center which has got the dermatologist, the intensivist together, and not take the thing. This is a very legally tricky situation. Patient given amoxicillin, they come for an infection here, they wouldn't tell the rash if it has been due to the triggering this, and if you develop certain reaction after giving an IV injection with cephalosporin, which we commonly use as a first take and therapy, we will all be in a very difficult situation. So thank you all the panelists for such a wonderful thing. So in summary, the allergic disorder is the most common non-communicable disorder which is going to come up. This is a major problem in pediatric practice. They are multisystemic, involving all the factors, and there are a lot of myths and facts associated. It needs a lot of counseling, and we also need to update ourselves with the latest guidelines and spend some time before we counsel the patients here. So I really thank all the LI Extreme panelists for doing a very great job of clearing all the doubts, and so I think we have questions. So Dr. Prasanna, over to you for further.
Thank you, madam. That was a wonderful panel discussion. So just the slog overs now, few boundaries and sixes you have to.
I think Dr. Soumya has already added a lot of answers to the questions.
I have 3 or 4 questions noted down. I'll ask one by one. Probably you can take this question, madam. Youngest age intranasal steroid can be started. Dr. Swati Kalra has asked. She has a patient 6 to 8 months.
So 2 years is the recommendation, but off-label you can use. Yes. 2 years is the recommendation even for mometasone and fluticasone, furoate also, propionate also, it is 2 years.
Yeah, only that's what we told already. It was up to 2 years, but one-to-one counseling. And if you're very clear, you are having an atopic history, you have the family history, and you are dealing with the case of an allergic rhinitis, I would go ahead and start. I think Neeraj will also, Dr. Suresh. Yeah.
Yes.
Next
Okay.
question.
But you'll have to counsel the parents and get an approval for the same. You have to get the approval because you're starting on a steroid. The moment the parent learn about steroid, they are going to come back to you, even if they're going to learn to. So better counsel, document in your case sheet why you are starting, keep the child with a close review, ask them to come back every month, and that will actually save your skin.
One of the participants has asked, is a BTK inhibitor available in our country?
Dr. Neeraj, you want to take this?
I'm not sure about that. I've yet to use it, but I've been told previously that yes, it is available.
Dr. Soumya? Yeah.
It is available, but not very commonly used yet in our practice.
Thank you, madam.
Actually, to be very frank, if you get a good moisturizer and a good bathing technique and use your topical steroids very judiciously, I have not gone beyond that. And we pediatricians are a little conservative compared to the dermatologists who use more of those. And in this stage, when you are going beyond...
BTK inhibitors, when I was reading, so it was showing that it is showing some complications like pulmonary infections and something. So we need to monitor them. So that's why I was a little reluctant to use BTK inhibitors now, and that's why we are just able to do it without that answer.
Another question.
I would actually involve a dermatologist at this level.
Yes.
Another question that has been asked is investigations for non-IgE mediated reactions.
Dr.
Is it
Dr. Krishna?
Is it regarding food allergy? If it is regarding food allergy, we have to go for a food elimination followed by an oral food challenge. That is the only possibility, because none of the IgE mediated tests like the skin prick test or the immunocap, that is totally useless for a non-IgE mediated reaction.
So type 1 hypertension.
Dr. Soumya, you want to add on? Because food allergy is your forte.
Yeah, Dr. Neeraj was adding something.
I was saying that type 1 hypersensitivity is mainly detected by either skin prick test or the specific IgE as discussed earlier. Type 4 hypersensitivity can be detected by patch testing. Type 3 hypersensitivity, depending upon the cause, like for example, hypersensitivity in rhinitis, sometimes IgG based test can be done. So it all depends upon that which immune pathway we are suspecting. But if there is no defined immune pathway, then at that particular time, it is the elimination followed by re-challenge that will be the right test, which Dr. Krishna has told.
I agree with both of them. I agree with both of them that in non-IgE mediated, it is food elimination, then clinical documentation of patient getting better, and then reintroduction.
Thank you, madam. And one of the participants has asked fluticasone or mometasone, which is your choice?
They both are same actually. They both are same. So like
less than young than 6.
Okay.
Dr. Prasanna?
Yes,
Dr.
sir.
Prasanna?
Yes, sir.
If time permits, can I ask some oral questions because I'm better at typing?
Sure, sir. Sure, sir. Please, sir.
Okay. Thank you, Dr. Narmadal and Dr. Panelists, Dr. Neeraj Gupta, Krishna Mohan, and Dr. Suresh. That was a very wonderful discussion. I just want to know, what are the dust mite control methods that you advise for parents?
Sir, can I take this question?
Yeah, please.
Yeah, please.
So dust mite is basically, we need to really understand that how it thrives. So for thriving dust mite, it requires two conditions. One is humidity and another is temperature. So in the presence of more than 50% relative humidity in the ambient atmosphere, dust mite is very happy and it thrives well. Similarly, the temperature is somewhere around 25-30 degrees Celsius. Around 30 degrees Celsius is very good temperature for dust mite growth. So if we take some measures which can reduce the humidity and probably change this temperature, then at that particular time we are affecting we can affect the growth. So we try to, you can say like, advise them to keep the humidity levels less than 50%. So that means that it should be somewhere in between 35 to 50%. So it all depends upon that in which part you are living. For an example, if you are living in Chennai or Tamil Nadu where the humidity level is high, the answer could be dehumidifier. in which in the dehumidifier you can probably keep or target a humidity level of 35 to 50%. Suppose if you are living in a part like Colorado, where the humidity itself is 0%, then at that time you might require a humidifier to keep the humidification level in between 35 to 50%. So the aim is to keep the humidity level in between 35 to 50. This is one. Similarly for the temperature. So for the temperature, we usually ask them to wash their linen bed sheets periodically, preferably weekly, in the hot water. The hot water should be more than 55 degrees Celsius or more than 60 degrees Celsius and then sun dry. Now you can always argue that the dust mite is actually not available in the bed sheet, in the linen. So it is there in the mattress. Then what is the utility of washing bed sheets in the hot water? So the utility is that in the bed sheet, the dust mite fecal matter, which is the allergenic material, which is the allergenic protein, which is there, and if you are washing it in the hot water, so that actually denatures that protein, that actually unfolds that protein, that denatures that protein. So the allergenicity of that reduces. So these are the two things. Then the third thing which is there is if you ask me one measure, which is the best measure, if you ask me, then one measure is basically the dust mite proof covers. We need to really understand that the allergenic material is the poop material and which is of the size of PM10 particle. PM10 particle means 2.5 to 10 micron. So we need a proof cover, dust mite proof cover, in which the pore size should be less than PM2.5, less than 2.5 micron. So a pore size is somewhere around 1 or 2 micron, tightly woven covers, which are the best one single measure. But then other measures like reduction in the humidity, temperature, frequent washing, no dusting, wet mopping, vacuum cleaning with HEPA filter, air purifiers will not help. I usually advise my patients to change the mattresses every 6 to 8 years because as per one study, every 10 years, the mattress weight increases to double. And in that extra double, 80% is because of the dust mite. So that is why I usually advise them to change the mattresses every 6 to 8 years. But it all depends upon the financial aspect of the person and different other measures. Then adequacy of sunlight, ventilation. So it is a multi-pronged strategy which you need to tell to the patient, not a single strategy. That is important.
Thank you very much, Dr. Neeraj Gupta. And in atopic dermatitis, occlusive dressing, do you advise?
Dr. KM, you can take this question.
Yeah. Yes, sir. Yes, sir. So in certain cases, when the symptoms are moderate to severe, we advise that occlusive dressing or what is called as the wet wrap therapy. We give a wet dressing using the drug and then we give a dry dressing over that. The only thing is that we have to do it in a very septic manner. Otherwise, it can lead to folliculitis. So it is not done for mild cases, only to some non-responding cases or moderate to severe cases only we give it. We can give it for the topical with the topical corticosteroids. Also with the TCA also we can give. The calcineurin inhibitors also we can give.
Yeah. Another last one.
I have probably used it once, sir.
Yeah, I rarely use because once I had used it and I developed severe folliculitis for that kit. So beyond that, I am not using that.
Okay. Instead of using coconut oil or gingerly oil, can we go for liquid paraffin? Because microorganisms do not grow on liquid paraffin, whereas other oils, fungal infections can occur. Can we go for liquid paraffin?
Yeah. KM, you can take
Yeah, if the patient's
moisturizers.
Yeah, if the patient cannot afford moisturizer, you can go for liquid paraffin. It may not be as good as the ceramide containing moisturizer and all, and it will work because in our government setup and all, it is the only drug which is available. In our place, only liquid paraffin is the only option if you are giving it free of cost. So we are using it and getting good results with that also.
Okay. Thank you. Thank you all so much. Thank you for your patient answer.
One important thing is about the liquid paraffin that it is only the occlusive. So it does not have its own moisturizing property. So the skin on which liquid paraffin is applied, that skin should be reasonably moist because the liquid paraffin is not going to moisture extra. It is only going to retain the inside moisture inside. That's all.
Yeah.
The 3 layers are very important, sir, because if the patient is going to be severe, they're not going to get improved only with the liquid paraffin. At that time, before using this, not adequately used a good moisturizer, you can't ask the steroid at that time. think the 3 layers are very important. There are brands that are available which are cheaper and which can be used for a short while. They could use that. I can't take it in the public forum. There are brands which are much cheaper than the commercially available ones. Locally sourced moisturizer, and I've been using it for a quite long time. It's been very effective.
Thank you.
Thank you. Thank you.
And somebody asked about nasal douching. I was just thinking we should have been elaborating on the nasal douching. Dr. Suresh, do you want to take this, or are you using, or any of the panelists? Nasal douching. Dr. Soumya, Dr. Neeraj.
Nasal douching, personally, I'm not using, but if anybody is interested, I can share with you one video of nasal douching. So it is a little bit difficult in pediatric practice. It is not that easy as we say, because the kids won't allow us to pump in that saline inside. That is all. But for adolescent and adults, it works really well.
Very effective.
Especially when the secretions are a little bit thick and mucoid, it will work.
Nasal douching is nothing but pushing the warm saline into the nose, and then it comes through the other side, being completely on both the sides. It has got a very beautiful video of the same, and for me personally, I've been using in adolescents and adults, and after her thing, I'm one of the persons who have been benefited by using nasal douching and have come down on my nasal steroids. So the videos are available.
But one very important point, which I would like to convey is that it should be used in a very aseptic manner with using a sterile, normal saline only. But there is some other practice which is called as gel niti, where water is used. But here in Kerala, we have a series of cases which resulted in primary amoebic meningoencephalitis after using this, after doing this.
You ask them to use the lukewarm water, or the saline is the best.
Yes. Yeah. So that has to be kept in mind.
So,
ophthalmologists are successful with the ocular allergies with olapatadine. Why not allergic rhinitis?
Studies are yet to come on the children, sir, and this is a recent change in guidelines in 2024 and 25. And we do not have olapatadine has to be used in combination with the mometasone. That combination is not available here, whereas azilastine combination, we already have it in the market. So if you need to use, we are using, and there is more in the adolescent and adult age group rather than the younger age group here.
Okay, thank you everyone.
Can we close this? It's already a 1.5 hours, Dr. Prasad.
More than that, and I don't know whether they will leave you or not. There are more questions coming up in the chat box.
Because it's a everyday practice. That's why.
Yeah, that is right. And one Anureka has asked about application of moisturizer and topical treatment time gap. Dr. Suresh, if you want to take this question.
What is the question?
Gap between moisturizing lotion.
That is when you apply moisturizer and when do you apply topical steroids. With that, I think it's the last.
Yeah, see, the very important thing is the moisturizer is immediately as we apply from the normal skin. That is very important. Affected areas, definitely we have to start applying the steroids. That is very important. And the technique of applying is more important, and the quantity of using moisturizer. And nowadays, the ceramide preparations are doing a lot of significant improvement.
Dr. Narmada,
I think moisturizer we apply immediately after. So 1 minute, sir. Moisturizer we apply immediately after the bath, whereas the steroid you could dry the skin and then apply it. Maybe give a gap of 1 hour. Yes, Dr. Jalil sir, we are expecting your comments as well as Dr. Venkateshwaran sir who has stayed with us.
Only one suggestion: in a neonate, better avoid any external application in order to prevent the early sensitization. No external stimulus in the neonatal period. Because once the newborn skin sensitized, later it will go for either atopic dermatitis or asthma. This is a provoking agent. So better avoid any external application. This National Neonatology Forum recommends that also. Thank you very much.
Thank you, sir. Thank you for your valuable point.
Not even gingerly oil or not even coconut oil. Just leave it. The skin will take care of that.
Yes, sir. Thank you, sir. So we have come to the end of the session.
Dr. Venkateshwaran has joined with us, past president IAP TNSC, just for 2 words from him.
Thank you all. It was an excellent session, and thanks to all stalwarts of allergy and asthma immunotherapy. And really, so many doubts, practical doubts, especially in application of moisturizer and the use of oils, use of liquid paraffin. All these are common doubts all of our pediatricians have in their day-to-day practice. All have been cleared. It was a very good session with all practical approaches. Thank you all.
Sir, Manohar sir, if all the subspecialty is over, I think we can have one more round of allergy and asthma.
True.
So
Actually, so
we will take up asthma now.
Yeah.
We can do that, sir.
Definitely. We will do it. Okay.
Thank you, sir.
Thank you. It was
I now request Dr. Tangaraj, our EB member, to say the vote of thanks and close the session.
Good evening, everyone. It's a very big opportunity to learn from the Stalwarts here, and today we had a very enlightening session. A big thanks to our teachers, Dr. Soumya, Dr. Liyas, Dr. Krishna sir, and Dr. Suresh sir. I would like to extend a thanks to our IAP TNSC President, Dr. Somasundaram sir, Secretary, Dr. Narmada ma'am, and Treasurer Rajkumar sir, and Academic Coordinator, Dr. Manohar sir. I would like to also thank our IAP Pediatric Allergy and Asthma Forum, Tamil Nadu chapter head Dr. Suresh sir, and Secretary Prasanna sir, and Treasurer Karthik sir, and other ED members Dr. Samyukta, Dr. Manoj, Dr. Vivek, and Dr. Anudeka. And I would also like to thank all our esteemed senior faculty who joined us today, and all the listeners who have been constantly doing there. More than 70% have been constantly doing there. And thank you once again.
Thank you. Thank you,
we
sir.
thank Dr. Prasanna for doing a wonderful
moderation.
I really appreciate his support. Thank you so much. And Dr. Narmada for doing a wonderful session. It was really awesome. Actually. Thank you so much.
Thank you, sir. Thank you all.
Thank you, everyone.
Thank you all. Thank you, Sean.
With this, I end the session.